Called to a 15-year-old male who had suffered a fall at school. On arrival, the patient was lying on the ground in the care of teachers. The patient stated that he had tripped on uneven ground and rolled his ankle whilst falling. The patient denied any loss of consciousness before or after the fall. On examination, the patient had generalized swelling over his left ankle with no obvious deformity. The left foot had a good pedal pulse. The patient stated having a 6 out of 10 pain in his left ankle. The patient was administered 3 mils of methoxyfluorine, which reduced his pain down to about 4 out of 10. All vital signs were within normal limits. The patient was unable to weight bear, so a vacuum splint was applied to his left leg, and the patient remained stable during transport to hospital for further treatment. Whilst I hadn't had any other possible fractured ankles during my prac, I had assisted in the treating of a possible fractured femur post a road traffic accident. However, the patient in the road traffic accident was actually able to weight bear and had denied pain relief, and therefore I think this would make it unlikely that he actually had a fracture. Compared to the patient in this reflection, which was unable to weight bear and was in significant enough pain to require methoxyfluorine. This case had happened quite late in my prac this time round, and I'd found that I was far less nervous with dealing with patients in general. I also specifically had a much greater confidence in applying the primary surveys as well as the pain and sample surveys compared to the beginning of my prac. I also had a much greater confidence with the application, the indications, contraindications, and side effects of the pain relief that we have been taught so far. Despite the fact that methoxyfluorine was the quickest and most appropriate analgesia in this case, I was reluctant to use it, as in the past the vapors appeared to have given me headaches in confined spaces, including within the ambulance with the vents on. I therefore had some concerns about how this would affect my concentration and therefore my overall clinical effectiveness. However, whilst a 2009 article by Greenlay and Babel stated that there was a chance of occupational exposure, it also states that it's unlikely to cause long or short-term health effects. The report also describes a restriction of administration of 2 patients per day per paramedic, as is similarly described in the 2011 QAS-CPM, Clinical Practice Manual. Based on this evidence, it seems unlikely that my headache was due to the methoxyfluorine and more likely to be due to another factor such as dehydration. So in the future, I'm going to ensure that I drink enough water before and during my shifts, and therefore I'll have no reluctance in administering methoxyfluorines within the indications and exposure guidelines set out by the QAS-CPM in my future practice.